And with that, I want to introduce Beth McManus, who's going to do our first talk. There you go.
All right. Thanks, Adam. So thank you, everyone, for the opportunity to present some of my research. For those of you who don't know me, I'm Beth McManus. I'm an assistant professor in this department. And so as Adam said, I'm also a pediatric physical therapist and practice both in early intervention, which I'm going to talk about today, and the newborn intensive care unit. So these questions about access to care and sort of systems of care for high-risk infants are very near and dear to my heart, and I'm really interested in many aspects of systems of care for these fragile and medically complex infants and toddlers, both in terms of access and utilization patterns, effectiveness and cost-effectiveness of these services. And so this is just sort of one example of kind of an interesting policy question related to access to care for these babies. So by way of background, for those of you who aren't familiar with early intervention, Part C of the Individuals with Disabilities Education Act, or IDEA, authorizes states to provide early intervention services for infants and toddlers with developmental delays and disabilities. And those services can include somebody like me coming out to the home, so physical, occupational, speech therapy services, sort of developmental specialist, family support services, and so forth, to help promote and sort of optimize the developmental trajectories of these fragile infants and at-risk infants. And in the last few years, probably in the last about 5 to 8 years, recent budget crises for early intervention, state early intervention programs have threatened the sustainability of the program as a whole. And a number of states, 13 in fact, have responded by narrowing their eligibility criteria. So the way early intervention works is by the letter of the law, children with developmental disabilities, so for example, Down syndrome or cerebral palsy, autism, hearing and vision deficits are automatically eligible for early intervention services regardless of the state that you live in. And then states have flexibility in determining among children without a diagnosis who have a developmental delay who will receive services. And some states are stricter than others in that eligibility. And essentially what happens is babies, infants and toddlers receive a full comprehensive developmental examination, and if their score falls below a certain standard deviation from the mean of what would be expected at that age, then the child would be eligible for services, and that varies state to state. And in response to budget crises, many states have made that gap much larger. So the effect of that is really unknown. If we think about sort of possible outcomes of restricting eligibility policy, it may be the sort of first assumption would be, or hypothesis would be, that it would mostly affect the children with mild developmental delays, because presumably they could be eligible 1 year, and then once the eligibility criteria becomes stricter, they're no longer eligible for services. So in that case, it would affect the children with the most mild delays, certainly not the children with the most severe delays, because in this hypothesis, because they would be eligible for services regardless. However, we also know from data from my colleagues who are on the paper, Steve Rosenberg in particular, that the number of EI-eligible children in each state far exceeds the number who are actually receiving services. And states struggle to serve even children with moderate to severe delays. So it doesn't seem to be that it's just the children with the mild delays who are affected. So it's possible that narrowing eligibility policies could be a marker for greater fiscal crisis within the states, whereby programming for children, it becomes diluted, right? So even though children are receiving services, those services are diluted, and perhaps they're not receiving the amount of services they should. So it's possible that the process of making EI eligibility criteria more restrictive may reduce EI access than if, for example, a state was consistently sort of narrow in its eligibility process, so eligibility policy. So if it moved from a moderate category to narrow, that might be more detrimental than maintaining that narrow category, which is what we hypothesized, but we really weren't sure. So it's unclear how and for whom narrowing EI eligibility criteria influences EI service delivery. And so these are the specific questions that we were looking to answer. And the first is there a gradient in strictness of state eligibility policy whereby stricter policy is associated with lower utilization? And then follow-up to that is narrowing eligibility criteria associated with lower EI access than having a consistently narrow eligibility policy. So moving from one category to something stricter, is that worse than for a child to access services than if you lived in that state that was consistently narrow? And then secondly, does the influence of state eligibility policy differentially affect children based on the severity of their developmental delay or diagnosis? And you might remember we had sort of two hypotheses about that it may mostly affect the mildly involved kids, or it could, on the other hand, affect the kids with more substantial developmental delays and disabilities because of the diluted services. So now I'll kind of talk more about the methods we use to answer these questions. So we use the 2009-2010 National Survey of Children with Special Health Care Needs. It's conducted by the National Center for Health Statistics, and it includes 750 children with special health care needs per state, and all 50 states are included. And I probably should define, if you're not familiar with the term children with special health care needs, those are children who require more medical services, more therapy services, more medications than other peers of their age, and because of a condition that lasts at least 12 months or longer. These kids also have either a behavioral or developmental condition. It's a nationally representative population, and the sampling scheme is identical to that used in the National Immunization Survey. The survey has a wealth of information. It includes a number of modules which are listed here. The sample for this particular study included 921 infants and toddlers, children with special health care needs between the ages of 0 to 2, because we were interested in early intervention access, which is from birth to 3, with developmental delay or disability that affected their function at least some of the time. So we wanted to create a sample of children who would be presumably eligible for early intervention services. So we screened out the kids who had just medication needs or whose condition affected their function, didn't affect their function, or affected it only mildly. So we wanted the kids with more substantial functional limitations. So our outcome measures was EI utilization, and it's measured in the survey via parent report. And the parents are asked, did your child's name, your Bobby, receive services from a program called Early Intervention? Children receiving these services have an individualized family service plan, which is essentially the care plan that delineates the child's progress and services, service delivery, and so forth. We included a number of infant and family characteristics, including the child's race and ethnicity, family income, parental education, severity of the delay and disability, and whether or not it was a developmental delay versus a disability. So again, this is an example of a bad slide, right, with the policy categories. So it's not so important what all the details are, but essentially we wanted to capture the strictness of policy, which had been captured by others before as sort of, narrow, moderate, or broad. So it was these three general categories based on standard deviations from the mean. And we wanted to capture that aspect of it, and we also wanted to capture whether states had changed in this time period between 2005 and 6 data and the 2009 and 10 data. And so in order to capture that, we came up with 8 categories. And so it ranged from the child just had atypical development. So a clinician would come out and assess the child and use clinical judgment to say that the child was developing atypically and the therapist would recommend services. Or they had less than a 25% delay in one area. So that's a 25% delay between their chronological age and sort of their functioning age on this developmental exam. And all the way up to having a between 1 and 1.3 standard deviation from the mean in 2005 and 6, and 50% delay in 2009 and 10. So you can see, if you do look at the detail of this, you can see the range of categories of strictness from just atypical development all the way up to having a 50% delay. So just to put that in context, if you have a 2-year-old, that 2-year-old would need to be functioning at a 12-month level to qualify for services in some states, which is a pretty substantial gap, and probably one that's bigger than we clinically would recommend services with a much smaller gap than that. So the analytic approach, I'll show you some descriptive statistics of the study sample and the prevalence of Part C early intervention utilization. And then to answer this question, so we have children nested within states, and so we wanted to account for that and account for both the between-state variability, which was our outcome of interest to us, and the within-state variability. So to do that, to parcel out those, we used a multi-level logistic regression model, random intercepts model. So we first fit a null model with no covariates to explain the between-state variability in EI utilization. We then included individual characteristics that I mentioned to determine how much of that between-state variability can be explained by the characteristics of children living within the state. Because we know that poor families, Black, non-Hispanic, and Hispanic families are far less likely to receive early intervention services than their white, non-Hispanic counterparts. And then finally, thirdly, we included a state eligibility policy to determine above and beyond the individual characteristics of children living within states, what's the role of policy to explain that between state variability and early intervention utilization. And then finally, to address our second study question, we were interested to know if the effective policy differentially affected children with differing severity of conditions. And so we included an interaction term, a cross-level interaction term between state policy and the severity of the child's developmental delay or disability. And the analyses were conducted in M+, to account for the complex sampling scheme of the National Survey of Children with Special Healthcare Needs. So now let's walk through some of the results. So again, probably not a great slide. Hopefully you can see it pretty well. But you can, just to highlight a couple of things, probably the racial and ethnic breakdown is pretty similar to what you would expect because this is a nationally representative sample, although it is a sample of children with special health care needs. So a little less than 20% of them were Black non-Hispanic, half of them were white non-Hispanic, and about a quarter or so were Hispanic. Pretty typical breakdown of male versus female, slightly more males because it's children with developmental delays and disabilities. And interestingly, about half of them had a developmental delay and half of them had a developmental disability. And you can see the distribution of how often the condition affected function. So about a third of them, it affected their function all the time. And then the distribution of maternal education, about 90% of them had a usual source of care, and about 11% of them were uninsured at some point in the last 12 months. And finally, about half of them were receiving early intervention services, which is pretty typical of what we see in national studies and other data looking at this, where if you carve out a sample of kids who are presumably eligible, we see fairly low rates of utilization among this group. So these are just unadjusted correlations. So just to orient you to the figure, along the x-axis are our policy categories. So one being no standard deviation. So there was really no requirement for a developmental delay, all the way up to the last policy category where they moved from a moderate delay to a 50% requiring a 50% delay most recently. So overall, there's this sort of negative correlation, whereas policy becomes stricter, it seems as though state rates of early intervention generally decline. And this was statistically significant, but this is unadjusted correlations. And so now let's take a look at the adjusted models. So these are adjusted random intercept multi-level models. And I also included race, ethnicity, family income, maternal education, child sex, and insurance status on the bottom. But to highlight a few of the statistically significant findings, first we see the null model. So we see the amount of between-state variability. And then when we control for child and family characteristics, we can see that having a developmental delay is associated with lower odds of accessing early intervention services. Having the more severe the developmental delay, the more likely children are to receive early intervention services. And although the parameter estimate is small, having a usual source of care was significantly associated with early intervention utilization. And then we include early intervention policy. And just for simplicity, we included it as an ordinal variable. And we felt pretty justified in doing that based on the correlation. And we see that as eligibility policy becomes stricter, children are controlling for individual characteristics less likely to receive early intervention services. And finally, the final model included that cross-level interaction between eligibility policy and severity of the child's condition. And it was that interaction term was statistically significant. And I know it's not helpful to really look at these interaction terms. So this figure is the adjusted predicted probability of early intervention utilization across those same policy categories. So the x-axis is policy categories, and the y-axis is predicted probability of receiving early intervention. And the red line is children with moderate developmental delays. The green line is mild, and the blue is severe. And what we actually expected to happen, so the mild is pretty much what we expected to happen as states became stricter. The rate of the probability of receiving early intervention would decline. What we didn't expect was we expected the blue line, the severe children, to be pretty much flatter than it was, because these children, as I mentioned, are eligible for early intervention services regardless of changes in policy. So that was an interesting finding for us. And they're also less likely than children with moderate delays to receive early intervention services across policy categories. So some conclusions. So there's significant state variation in early intervention rates that can be explained really in small part by the restrictedness of state eligibility criteria. So there's obviously more going on. If you looked at the amount of between state variation across the different models, we weren't really able to account for a lot of the state variability. Children with the most severe functional impairment seem to be particularly less likely to receive early intervention services, especially when the policy becomes more restrictive. So the study has, of course, a number of limitations. It was cross-sectional, and it assumed, so we can't infer causality, it assumed a uniform rate of Part C services within states, which we know isn't really true. There's a tremendous amount of variability within states regarding early intervention access and utilization. We were just looking at a yes or no question about early intervention utilization, so we can't really examine service quality and timeliness. And finally, Part C utilization was collected by parent report, which has been criticized by some. However, there's a number of studies to support that parents can pretty accurately report what services their child are receiving. No one has specifically looked at early intervention, but they've looked at other mental and behavioral health services. But it does have a number of strengths. It was a nationally representative sample of children with special health care needs. It examined current and previous policy. And it looked at important interactions between policy and delay and disability severity with somewhat surprising findings. So what are the implications for policy and services? So in states that have adopted more restrictive criteria, so families of children with multiple disabilities or risk may have greater difficulty finding a skilled provider. Or it's also possible that the stress associated with coordinating multiple appointments across different therapists and subspecialists could result in lower rates of early intervention utilization despite presumed eligibility. And finally, states with less restrictive eligibility may have more extensive child disability services that make it easier for families to access services. So these findings, we think, have important clinical implications for pediatricians to ensure that families of children with complex developmental conditions receive early intervention. And the findings indicate the importance of statewide surveillance for children with special health care needs to monitor utilization of early intervention. And the other thing that I didn't add was that it can set the stage for future research, so to address some of the limitations in terms of parent report and really being able to determine where these children are receiving services and how much. And we can look to a data set like Children's Medicaid data and use data from states where policies have changed and look before and after to determine, what kinds of services children are receiving, the sort of dosage of them, and kind of potential outcomes from that. And that's a project that we're proposing to do very soon. So I think that's it. So I'm happy to take questions. No questions. Okay.